Good afternoon to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Sania Hasnan. Ma'am is MBBS MD, Hospital Administration, COO at 3 Peak Health. With the help of Ma'am and her wonderful insight, we will be taking a close look on today's topic, which is International Patient Safety Goals by JCI. Now, without any further delay, I would like to welcome Ma'am at our forum and would like to hand over the session to her. Over to you, Ma'am.
Thanks a lot. And hi, everybody. Thank you for joining. Good afternoon. So today's session is around international patient safety goals ensuring how, as doctors, we can keep our patients safe. And when we say JCI, that's the Joint Commission International. This is an organization that you all must have heard. Hospitals in India like Apollo, Fortis, and so on are accredited by Joint Commission International. You must have heard of NABH, etc. These are accrediting organizations that carry out a peer review, ensuring, and they have a set of guidelines that ensure that patients are, managed within a safe environment. Now, as doctors, one of the first things that we learn is first do no harm, right? That's one of the first tenets of healthcare and medicine. As doctors, we must ensure that we cause no harm. But no, very often unknowingly, a lot of harm happens to patients within a hospital premise or while they're trying to avail healthcare services. You all may have heard of instances where a wrong surgery has been performed on the wrong side of the body, a wrong leg or a wrong arm, or a wrong patient has been taken in, or during a surgery, an instrument or a gauze piece has been left inside the body. Patients have a fall inside the hospital, or a wrong medication gets administered, and so on. Many different errors that happen within healthcare. There was a study done in America. This is many years ago, 2009, where they said the number of medical errors that happen just in America. We have limited data in India, etc. You can extrapolate it globally. Is equivalent to two Boeings, hitting mid-air. That's the number of people that get affected by errors on a daily basis. That's how high errors are in healthcare. And like I said, it's very important that we're very careful, very conscious of different things that we do. There are multiple different areas that we should focus on to ensure that patients are kept safe. But we'll talk about some of the top patient safety goals that JCI discusses about. Now, let's look at the first one. Very simple. Identifying patients correctly. That's one of the most important, so that you don't make a mistake. You don't give an intervention to a wrong patient. Now, let's talk about when should we be identifying a patient correctly and how should we be identifying a patient correctly. To answer the how, you should always use two identifiers at any given point of time. We would suggest the first identifier being the full name of the patient, followed by something that is a number. So you've used a word which is alphabetical and the full name, followed by a number. The number could be their date of birth, it could be their phone number, or it could be a unique ID. But something, I would prefer it to be a phone number, something that the patient in turn can also validate, right? So you would say, let's take a name. For example, hi, Sangeeta Basu, instead of just saying Sangeeta, right? There can be 10 Sangeetas if you're saying, hi, Tanya Sharma, for example, right? There can be multiple Tanyas. There can be multiple Tanya Sharmas as well. But hi, Tanya Sharma, did I get your name correct? Is this your phone number? And then you repeat a certain number. Most people remember their phone numbers, right? And they'll say, yes, this is, so you've identified that patient correctly. It's very important to have two identifiers, either the name and the date of birth, because people know their date of birth. it's highly unlikely that two Tanya Sharmas would be sharing the same date of birth. It can still happen, but would they be in the same hospital, the same ward? Quite unlikely. So always using two identifiers in case of trying to when you're trying to identify patients is a very good habit as doctors. Whenever you're talking to a patient, you're especially carrying out any intervention, that is the point at which you must try to identify your patients correctly. Now, what are these points at which errors can happen? One is when you're admitting a patient, a new patient is coming, you're writing the admission notes, you're putting them in a certain ward, you're going to plan the entire care of plan for the coming 24 hours, 2 3 days, and so on. So when you're building an entire care plan for a patient, you have to identify the person correctly, so you're giving the right treatment to the right person. So during admission, that's one thing, that's one time where you have to identify, like with the two identifier. Then, if you're transferring a patient to another unit, when you're moving a patient from a ward to the ICU, or you're moving up, or there's a step down from the ICU to the HDU, or you're taking a patient into surgery, etc. During that time, it's important that you identify the patient correctly using two identifiers before administering any medication. So, if you're giving any medicine, right, that's the time. So you would have their, for instance, you would have a wristband on them, you check their name, you check their number, you ask them, if they're awake, if they're not if they're not under anesthesia or sedation, etc. It's always important, it's nice to talk to the patient and ask them, hi, did I get your name right? Is this your what, can you tell me your date of birth, and reconfirm that before withdrawing blood from to get a patient's blood sample, or before administering any blood or blood products, not just medicines, before any procedure, whenever you do a procedure for a patient, before carrying out any procedure, and even before you try to give them a restricted diet. So these are different events at which we must identify a patient using two identifiers. Let's look at the second important patient safety goal. Again, I can't emphasize enough the value of this, that is improved effective communication. Now, communication between caregivers, for example, between two doctors, you've had a busy day, your shift has finished for the day, you pick up the phone and you tell the next doctor on duty, list the things that they have to do. That's typically how you do a handover, and then you go home. Now, when you are giving details to a patient over another healthcare provider, it could be another doctor, a colleague that you're handing over to, it could be a nurse that you're giving instructions to, it could be a senior consultant, you're telling them about the patient details, etc. Now, during all of these times, it's very important that we communicate effectively. Verbal communication, great. In some cases, yes, we pick up the phone but if you're taking a patient care order, number one, if you are reporting a critical diagnostic result, number two, and number three, if you are involved in patient handover, in all of these things, the verbal communication must be followed by written communication as well, so that you do not make errors. Is to ensure that this is done to ensure that the patient data is accurately and correctly understood by the recipient. So your verbal communication, be slow, be clear in your words. There's something called uh, talk back, repeat back. So when you are giving an instruction, for example, about a medicine to be administered, or about a procedure to be done, maybe dressing to be removed, a catheter to be removed or inserted, the dose of a medicine. So when you tell these instructions on the phone, the person who is receiving that, always ask them to repeat back, right? So that's a double confirmation. You have said something, they may have misunderstood. People have different accents. The voice on the phone, maybe, there may be disturbance on the phone, and so on. So in all of these cases, it's called read back, repeat back. I would always ensure that if I'm giving an instruction or somebody is giving me an instruction, I would always advise write it down. And then when you write it down, please read back to me what you have written. And that way, I'm quite confident that there's a lesser chance of an error happening, right? An L and an M here An N and an M, is very easily misunderstood. These are simple things we do while talking on the phone also, right? When you call out somebody's name, when somebody's trying to write an email address, you spell out, you'll always try to say November, Delta, Charlie, etc. Why do you do that? Because you want the person to understand it correctly. Similarly, in healthcare, when you're giving an instruction, you're on the run, you've given 10 instructions to the nurse and or to another doctor for during a handover, and you're done. You can imagine the amount of error that can happen in these cases. Again, that's why I repeat, for communication to be effective, always follow a read back, repeat back policy. That is, when you have given an instruction or you are getting an instruction, write it down and read it back clearly for the person to understand. Especially when you're talking about a patient's condition, you're in for example, you are on night duty and you call up a senior consultant telling them about patient that's come in probably with an acute coronary syndrome. Now, in that case, how will you communicate that, right? Or even in case of handovers, how do you hand over communication like that? So the there's a mnemonic that we use. It's called ISBAR. ISBAR. I for introduction. Introduce yourself. Why you calling? S is for situation. Tell me about what's the latest situation. B for background. Give me a background on the patient. A, assessment. Tell me about the assessment that you have taken. And um, sorry, R is a recommendation. What is your recommendation? So let's get into a little more detail over here of ISBAR. Introduction. So if I'm calling up a clinician, a doctor, or even if I'm trying to give information about a patient, I'll say, hi, I'm Dr. Sanya calling from the ICU. We've had a patient who's had an acute coronary event. Then you give the situation so that the person knows, okay, this is an emergency. No, this is a regular call. So the situation, right? That this is an emergency. There's an acute coronary event versus I'm calling because the patient is running fever or the catheter has come off, blah blah. So you give a situation, then give the background. This lady came in. She was 48 years old. History of hypertension, no cardiac events in the past, and so on. So given a little background to the patient. ISBA, an assessment, I did the vitals. These are my findings. You auscultated the chest. You probably ran some quick tests, etc. You have all of that. So you've done an assessment. And my recommendation is, can we do this, this, this? And they'll say, yes, you can go ahead and add one, two, three more things, right? That's how your communication must always go. So remember, and if you don't remember, just write down ISBAR. The rest of it you will know on your own, right? As doctors, you know what to do, but it's just structuring. So introduce yourself, who are you, situation, what just happened, background, who are we talking about, a assessment, what have you found, and our recommendation that this is what you suggest, but tell me what should I do. That is the correct way of communicating with anybody. So remember, a read back, repeat back is a must. Ensuring that communication, as much as you are talking, you're ensuring it's also written down. And the third thing is following a structure like ISBAR. That's introduction, situation, background, assessment, and recommendation in your communication. Lastly, documentation in healthcare is very important. I think all of you understand. Anybody who's practiced even for a few years would know something that's not written is not done. The only proof of things being done is when they get documented. And that's why it's important that we document everything correctly. And yeah. Now, let's look at the next patient safety goal. Again, a very interesting, very important. Very often we come across errors. This especially in case of high alert medication. Now we are, like I said, we're on the run. There are so many medicines being given to patients on a daily basis. High alert, you can't be careful about everything, but there are certain category of medicines when you are working with them, that's the point at which you need to stop and think, what are you doing? Because on most other times when you're working, you're so used to it, you're so well experienced that you're running on auto mode a lot of times. You don't even need to pay attention to what you're doing, right? It just comes naturally to you. But that is a point where there's a possibility of making errors in case of high alert medication. High alert medications are medications that have a potential of causing harm when an error happens. These are typically seen in something called the LASA, LASA medicines, that is look alike, sound alike medicines. There are medicines that look alike. If you look at this picture itself, right there, if we've seen so many medicines. We have so many medicines in our own houses, in the hospitals, etc. We see a lot of them look very similar. Your cetirizines or alprazolam, etc. They look so similar. Loperamide, and so on. You can't tell one from another. Now imagine if these are in the pharmacy and they're all lying together. And there have been instances where the pharmacist has picked up a wrong medicine and given it to the patient. Um, there are medicines where an error may not cause an adverse event, but then there are other medicines where adverse the patient can have a severe harm because of the medicines that you're giving. So one needs to identify. So you will see in hospitals and in clinics, what we do is we have a separate cupboard for high alert medicines. So you have all the cupboards, and you can keep pulling out medicines and giving it to your patient. But high alert medicines will be kept under lock, because when you're in auto mode, like autopilot, right, without thinking, when you're working, which is fine, you're working like that, you open a cupboard, you give a medicine, you open another cupboard, you give a medicine, you're doing different things. You try to open a cupboard and then you realize, oh, it's locked. And that's the time you come out of your auto mode suddenly, and you're attentive. And that is why these different guardrails are put in place in a hospital. For example, medicines being put under lock and key, high alert, because it breaks that auto mode and gets you thinking, okay, now because I have to unlock this, I am looking at a high alert medicine. I have to be careful. I cannot run in autopilot. What are the high alert medicines that will be kept under lock and key, or would be kept under double doors? So instead of opening one door, you're opening two doors, probably one with your right hand, one with your left hand, just to break that autopilot mode that we tend to be working on. Medicines like adrenaline, atropine, adenosine, potassium, any concentrated electrolytes, insulin, any narcotics, chemotherapeutic agents, heparin, and so on. These are typical medicines that will be kept under double lock and key. They'll be kept separately, and so on. So, like I said, very often working in autopilot, we always see guardrails put in place to stop that autopilot functioning, so that you don't make an error. This is only for your high alert medicines. Now, second category that I told you about is the LASA, look alike, sound alike medicines, right? What happens in case of these medicines? For example, there's a brand name called Almex, and there's a brand name called Almo. Now, from the phone, I call up and say, give the patient Almex, or I tell them give the patient an Almo. You almost sound very similar. They have three alphabets that are the same: ALM. One is ALMEX, and the other one is ALMO. So medicines that have this kind of spellings, where 3 to 4 letters are exactly the same, these are called sound alike medicines, right? And as you see this image that I have here, you can't, all of them are round, same size, white, silver packaged medicines. These are look-alike medicines. So whenever you're working with these medicines, it's very important to label them correctly, keep them far away so you can reduce errors. That's what we do. So in case of sound alike medicines where the alphabets are in capital, Almex and Almo, let's take an example. What we will do is one medicine, for example, Almex, will be written in yellow, with ALM, written in small, and EX written in capital, so you can, make out the difference. And the other one would be in red. So, you're using a mixture of capitalized and small letters just to draw attention to the right places, so that you don't make an error. And you will see in pharmacies, all good pharmacies, look alike, and that's a rule that we abide by. Look alike, sound alike medicines are kept diagonally opposite each other. So they're never kept next to each other. They're always kept diagonally opposite each other so that there are lesser chances of making mistakes. They are usually labeled using yellow, bright yellow, and bright red color so that you can tell one from another. So there, so like I said, labeling the drug properly, storing the drug in case of high alert inside lock and key, put a high alert sticker, etc. In case of lookalike, capitalize the alphabets that you want to emphasize on so that you can, and color them, between yellow and red. You'll notice even when uh, high alert medicines are being administered in a hospital, you very often ask for two nurses to be there, one to read out and the second to check, because it's an adverse event, it's a sentinel event if you end up giving a wrong medicine to a wrong patient. And in that case, you check, double check, right? Independently, they have to check. One person checks and the second person checks the same thing. Is the infusion pump properly set? Is there a proper dilution to it? Was the labeling correctly done? And closely monitor the patient, etc. So that's the way of administering any kind of high alert medication. So drug safety is again very important. A couple of other things you must check is right route, right dose, and things like that. Now, this is interesting. Ensuring safe surgery. When we take patients into surgeries, of course, there were other things I spoke about that, all add up to patient safety. For example, identifying the patients correctly, communicating correctly. One very interesting aspect of surgical safety is the surgical safety checklist. You must have, or a lot of you must have come across that. There's a surgical safety checklist, that a list of things that you check before you start the surgery. And one of the important things during a surgery is to empower the entire team to be able to speak up and ask anybody to stop. So whether it's a nurse, or if it's a senior doctor or a junior doctor, or an OT assistant or an anesthetist or the ortho surgeon, or whoever it is in the room, right? Anybody, if they have a doubt about patient safety, they should be able to say stop, which means everybody stops. And then you relook what's going on, right? You read through, okay, I have a doubt, this doesn't seem right. Everybody should be able to stop. So that's why it's important to empower. You would have seen in India, in a lot of hospitals, there's something called a speak up campaign. A speak up campaign is where people who feel a little, you know, how do I put it? In healthcare, it's a little bit hierarchical. We would all agree, and it's not very easy for everybody to speak up, even when they see something wrong happening, because you're scared. There's somebody senior, there's probably a big doctor around, etc. And that often can cause patient harm, and that's why hospitals encourage the concept of speak up. So you see a lot of speak up posters, in hospitals, especially that are JCI accredited, that are NABH accredited, so that these errors that happen, are reduced and everybody's empowered. A surgical safety checklist is a mandatory thing to check. That ensures that you've got the right patient, you're doing the right surgery, all your equipment are working, all your instruments are in place. You know what the surgical team is. Once you've done that entire check, it's usually the anesthetist who starts it, or it could be a junior doctor. Once everybody has gone through that list together and you say ready to go, that's when the surgery is started. So that's ensuring safe surgery. Another thing, again, I think this is a little underrated, but it's again very important. Reducing the risk of healthcare associated infection. Now, healthcare associated infection, also called HAIs, are the worst type of infections because these are highly resistant microorganisms. They've been within the healthcare setting. They're very difficult to deal with. It's best that you prevent your patients from having it. And one of the simplest, most underrated, cost-effective way of reducing infections is hand hygiene. Washing your hands before any procedure, using a hand rub where hands are not visibly dirty or you've not had contact with any liquid. So hand hygiene, very important. Next thing is biomedical waste management, to ensure there is no infection in and around the hospital, and using standard precaution, wearing your personal protective equipment, etc. Right? That's now hand hygiene. When does hand hygiene become important so that you are not causing any harm? Simple one: before you touch a patient, use a hand rub. You notice as doctors or any senior consultant would come and use a hand rub, and then check the pulse of the patient, or touch the patient. Before any clean aseptic procedure, use a hand wash, right? And then after any body fluid exposure, use a hand wash. After touching a patient, then you go touching the patient's surrounding, or you're going to touch the clinical notes, etc., your pen, and so on. So after touching a patient, again, follow hand hygiene. And even after touching a patient's surrounding, must use must perform hand hygiene. Now, hand hygiene can be, there are three types of hand hygiene that we have in a healthcare setting. We've got the hand rub. Uh, when you're using a hand rub, especially, of course, we all understand everything that's available in the market. That's not the kind, and that little drop that you put on your hand has no value. There should be enough. How much hand rub should you use? There should be enough hand rub. There's no standard quantity really, right? It all depends on the size of your hand. There should be enough hand rub in your hands and palm, so that when you're using the hand rub, it should last at least 20 to 30 seconds. If it finishes off in 5 seconds, it's not going to do anything. So take enough hand rub so that when you're using it, it should last for at least 20 to 30 seconds in your hands. When you are washing your hand, spend at least 40 to 60 seconds washing your hands, right? Just go and, 10 seconds, your hands don't get cleaned in that much time. So medical hand wash, and then of course surgical hand wash. Before a surgery, we spend at least 3 to 5 minutes in case of a surgical hand wash. Right. So the next thing in prevention of infection is biomedical waste management. Again, very important, especially as healthcare workers. We should be very careful about what we throw where. This is not just infection control, but this is also for the safety of other healthcare workers, especially those who are managing the biomedical waste, because needle prick injuries, every needle prick injury is our, that happens because of a biomedical waste, would be our fault, because we have not thrown it in the right place, right? And the person who is managing the biomedical waste would not anticipate that you're not taking care and you're not throwing. So there's the needles are to be thrown into the sharps container, all so the yellow container is for all infected waste, anything that can be incinerated, right? Black is for your general waste, and red is for your infected plastics and rubber. Blue is used for broken glass, and like I said, you have a sharps container. So always remember, there'll always be a sticker telling you what goes where. The only and the right way of biomedical waste segregation is at source. There is no concept of segregating waste afterwards. That is not the way to manage. Waste must always be segregated at source. And the last thing that we must take care is use of proper PPE, personal protective equipment, where needed, wear your cap, your gown, mask, your goggles, gloves, and so on, so that you're not causing harm to yourself and your patient. Coming to the last one here, so reduce risk of patient harm resulting from fall. Now, falls are also surprisingly common in hospitals, right? Patients fall because it is very important to identify patients who are at a high risk of fall. So there's a fall assessment that one does, especially when patients come into the emergency or they get admitted into the ICU. Sometimes we don't take it seriously. We wonder why these are in place, because we've learned this with years and years of experience within the healthcare that there's a high chance of patients falling if they are one, two, three things, right? For example, if they're on multiple medications, if they've had a history of fall in the past, if they have any neurological disorder that affects their gait, if they are under any kind of sedation medicines that cause dizziness, and so on. So, it's very important to identify these patients. Fall obviously adds to the burden, right? They may end up injuring themselves, breaking, fracturing a bone, causing a head injury, and so on. So, again, another very important, especially if a patient's had a post surgery patient comes into the ward, you've seen it's always very important to have the grab rails up when they're on the bed. You have grab rails everywhere in the washroom, etc. You've got all floors that are labeled, the quality of the material on the floor, if there's water fallen somewhere, etc. All of these things are so important. So usually the hospital management takes care of all of this, but as doctors, what is our responsibility? Our responsibility is to identify patients who are at risk of fall and making sure that we label them, right, so that everybody who's working there understands, okay, this is a high risk of fall. We need to be more careful when they need to get up or they need to move around, and always ensuring that the bedside rails are lifted up so that somebody doesn't fall. So these would be a few patient safety goals that as clinicians we must abide by. Very often we don't have this as a part of our studies during our MBBS or even during our MD courses, but one tends to learn this in a hospital setting. But yeah, when be attentive, be alert, see what's happening around your hospital. Most hospitals that are, especially those that are NABH accredited or JCI accredited, etc., they definitely follow. For them to continue with their accreditation, they have to follow this. They'll have posters, they'll have trainings happening from time to time. But then there are a lot of other hospitals also. Ideally, every healthcare setup must follow patient safety goals to ensure that you keep your patients safe. And as doctors, it's very important each of us keeps these in mind. So we talked about identifying patients correctly. We talked about effective communication, ISBAR. Talked about medication safety of LASA drugs and high alert medication, surgical safety, reducing chances of hospital-acquired infection, and reducing chances of patient fall, injury because of patient fall. So these were some of the patient safety goals. That's all. That's from my side. But happy to take any questions if there are.
Thank you so much, ma'am, for this wonderful presentation. We do have some question if you like to take that up.
Sure.
Okay. So, ma'am, the first question is, how can you ensure accurate patient identification during every patient interaction?
Right. It's a very simple thing, right? So when you say during every patient interaction, right? What's important is once you've identified a patient, then further interactions don't need any change, right? As long as the environment is not changing. So if you walk into a patient's room, for instance, you are tell them, hi, I'm Dr. So and so. Are you let's say Tanya Sharma, for example, right? And they'll say, yes, I am. Can you please tell me your date of birth? They'll tell you the date of birth, right? So you say, okay, your name is Tanya Sharma and your date of birth is this. Can you please repeat that? Once that is done, after that, whether you're taking history at the same time, you're giving a medicine, even if you have multiple interactions, you don't have to constantly check the patient. You don't have to re-identify a patient. But once you've identified, as long as the situation or the scenario doesn't change, you don't need to every time. But other than that, right, you go into the emergency, identify the patient, you have to, right? And it always has to be true. The name and the date of birth are the easiest. Otherwise, the name and the phone number depends on what your hospital policy is, right? Some people also say name and hospital ID, but hospital ID is something that at least a patient cannot validate that, right? That nobody remembers. So it's best to use something that the person can also confirm. So in all interaction, like I said, on admission, when you're meeting a new patient, and especially important, events, right? You're giving a medicine to the patient, you're drawing blood. These are the events, right? Can you please repeat your name? Can you please repeat your date of birth, right? That's you walked into the patient's room the first time today after, let's say, 2 days, and you were on duty, you've never met this patient before. You're supposed to go and draw blood. You walk into the patient room, introduce yourself, tell you can tell greet them by their full name. What This is your name. Can you please tell me your date of birth? And once you've confirmed that, it hardly takes 10 seconds to identify a patient.
Thank you, ma'am. The next question is, what are the common high alert medication used in your practice, and how can you ensure their safe administration?
Right. So high alert medication that we use in practice are all medicines like adenosine, atropine, concentrated electrolytes, potassium. These are all very available in any hospital setting. Chemotherapeutic drugs, heparin, insulin, for example, is so commonly used. Um, to ensure safety of high alert medicine, there are two things that I take care of. One is we keep it under double lock and key. It is to stop you from being in the auto mode and get you thinking. Suddenly you realize, oh, this door isn't opening. Then you think, okay, I have to do something differently. That makes you more alert. So putting it under double lock and key, that is number one. Number two, labeling them. Big bright red, green, yellow labels so that it draws your attention. That's number two. And number three, while administering the drug, when you've taken out the medicine, have two people check everything independently. It might take a couple of extra minutes, but it's almost, it's preventing a sentinel event from happening. So, if a nurse is to administer these drugs, two nurses must check it independently. So one nurse does all the checking. You'll see some hospitals, they also make you document. Two nurses will document. So they'll check and they'll write it down. Then the second one will check and then she'll write it down. And then you read that and you confirm you've got the right medicine and then you administer it to a patient. And it's only for a handful of, you know, 8, 10 medicines. The rest you can keep working with very quickly. But these you have to stop and think. And these are the guardrails. Labeling, lock and key, and double check independently during administration.
Then, ma'am, there is one last question.
Yeah.
What protocol should be in place for handling high alert medication, and how do you ensure compliance?
Uh, Ensuring compliance. That's a good question. I mean, I work as a hospital administrator and within the management, and I personally uh, I feel that any kind of penalization or punishment is it's not something we do. So ensuring compliance in a hospital is always a very encouraging, motivating activity. To one It has to be done in a manner where one you constantly train your team, right? You constantly make them aware, you talk about it. Your team will only look at things and value things that you yourself are talking about. So you always talk about, you always train, retrain. If you see, good hospitals would have training around especially these important things on a monthly basis, or every 3 months, on the go. When you take rounds, everybody has morning rounds, right? For some reason you'll have the hospital administrator or the management team, or you have a senior nurse coming and taking notes, or even doctors taking notes. Just ask, can you tell me some highlight medication? Can you tell me what's happening? So that, okay, your seniors, your the leadership team is asking these questions. That means it's so important. Maybe once or twice or thrice they may not be able to answer, but the fourth, fifth, sixth time, people will eventually start, remembering that, okay, I always get asked these questions. So you have to inculcate a habit. That's one. The second, like I said, how do you manage? Again, it's the same thing. You keep them under lock and key. You have these tools and you keep iterating. You keep training your team and you keep asking them, uh, you know, what do they know? Just, a random check of whether this is being followed is good enough, to drive a certain behavior. So it's a lot of training, a lot of inculcating habit. And it always has to be top down. If the leadership believes in a certain value, the rest of the team will. You never punish, you never reprimand, you never penalize anybody in the hospital for anything. Hospital needs to be a very encouraging an environment. People shouldn't be scared of making an error. Again, that's a very important thing. You shouldn't be scared, because then what will happen is errors will be hidden and people won't tell, and then the system will not be able to improve. So it's very important that people should be able to say, hey, I made an error. It's because there wasn't a process in place. What can the management do to fix it so that I don't make this error? That's the way we would have a hospital working.
Thank you so much, ma'am, for answering all our questions. That's all from our audience. So, ma'am, before concluding, any take home message from your end?
Right. So, like I said, going back to the most important tenet of healthcare, that is first, do no harm. Keep that in mind. Take care of your patients. They are your responsibility. These are simple things. There's a lot of damage that gets done in a hospital because of, errors that happen unknowingly. And if you cause an error, never be afraid of going to your management and letting them know. It's the responsibility of the management to prevent errors. It's never a person's fault, right? If somebody fires somebody, or somebody punishes somebody for making an error or replaces somebody, the next person will come and make the same error. What's important is that the hospital puts a guardrail in place, creates processes that prevent errors from happening. It's never a people problem. So never be afraid of pointing out, hey, an error happened, because I care about my patient safety. If I made this mistake, others can as well. So speak up, voice up. Your patient's your responsibility. Take care of them, keep them safe, and yeah, that's all from my end. Thank you so much.
Thank you, ma'am, for joining us today. And with your permission, ma'am, I would like to conclude today's session. Thank you.
Thank you so much.